host of Researcher Revealed. On today's episode, we are out in the wild, so you might hear a little extra background noise. And we're here at the British Association for Nurses and Cardiovascular Care conference. I've managed to secure a little bit of Professor Ian Jones' time, and he's going to join me to tell me a little bit more about what he does, his role, and what led him into research. I hope you enjoy. Hello and welcome to today's Researcher Revealed. Today we have with us Professor Ian and he's going to talk to us all about his journey as a nurse researcher. But as you know, before we get to that, first we get to know you a little bit better. So I'm going to ask you 11 rapid fire questions. Just tell me the first thing that pops into your head, okay?
Yep.
Are you a Windows or Mac?
Windows.
Tea or coffee?
Neither. Don't drink hot drinks.
Ooh, interesting. When you're writing, music or silence?
Silence.
Okay. Where do you work?
Liverpool John Moores University.
And is that where you work all the time? Or do you ever work remotely?
I work remotely, I work from home, and I sometimes work in the NHS.
So everywhere.
Yeah, absolutely.
Excellent. And what time of day is your most productive?
First thing in the morning.
Okay. And what's your favorite referencing manager?
I don't really use them. I'm quite old school.
Oh,
Yeah.
controversial.
Yeah, I'm quite old school.
Okay.
Yeah.
What about when it comes to data visualization? What do you use to...
Again, old school.
Old school?
Yeah,
Nice.
Yeah, absolutely. Just tend not to use too much tech whether it's due to analysis or whether it's writing, tend to be quite old school in that respect, yeah.
Nice. Favorite desk snack?
I tend to eat a banana first thing in the morning because when I get up I'm not ready for my breakfast, but I'm still hungry, so a banana usually does the trick.
Perfect, thank you. When you're planning or organizing, I'm going to guess I know the answer to this one. Are you digital or analog?
I tend to...
Analog being paper.
Yeah, no, I am actually quite technologically sound in most things. So I will use digital. I'm very much a spreadsheet type of person, so I use Excel a lot for planning my day, planning my week. So I have a spreadsheet where yellow is for everything that has to be done today, blue for everything this week, and red for the longer term.
Love it. Never thought of using Excel as an organizer. What book are you currently reading?
It's Backbone of the Nation, and it's actually about the miners' strike in the 1980s.
Oh,
interesting. I come from a strong Welsh mining community.
Oh, very cool.
Yeah.
And last question is, who is a researcher that you admire?
I think that the two people that were actually my PhD supervisors, Martin Johnson, who has recently passed away, was one of the most inspirational people that you'll ever meet. Very moral, taught me how to be a better person, not just a researcher. And then David Thompson, who most cardiac nurses will know Dave, who's sort of the godfather of cardiovascular nursing, and so a PhD supervisor, but also a mentor for many years after.
Excellent, thank you. Perfect. So without any further ado, like I've said to you before we started the camera, this podcast, Researcher Revealed, is all about trying to get to know the person that's behind the research. So to turn it from being, you read a paper by I. Jones, people know you a little bit more. So tell us who you are, what you do, and why you're in research.
Okay. So who I am, I mentioned earlier, I come from a very strong Welsh mining community, and that gave me, I suppose, my roots in looking at inequalities in health. I'm very passionate to ensure that we serve all the community and not just certain elements of the community. I left home at 18 to travel to Walsall in the West Midlands, near Birmingham, to do my what was a nurse training in those days. Travelled all around the UK working as a staff nurse, charge nurse, nurse manager, various coronary care units, cardiac rehab, etc. And ended up in Salford in Greater Manchester, where I did my my grounding in education, and wanted to know more and more. One of the things I'd say is that I'm extremely inquisitive, extremely nosy, want to know how things work. The child that took apart the watch just to find out what the components were. Wasn't very good at putting them back together again at the end. but certainly took it all apart with a better idea of how it all worked. And that's where my research came from. My research ideas came from. Well, why are we doing this? Why are we doing this? And then started doing some research, then a PhD, and then more and more research after that. And when we think that 90% of care is delivered by nurses, but we have very little evidence to support much of what we do, and I saw much of what my great friends and ex-colleagues, people like Linda Blue's work in heart failure, Jane Corn's work in thrombolysis nursing, all these really key people that dramatically changed how cardiovascular nursing progressed, Dave Thompson in cardiac rehab. So all these kind of people made a real impact on me, and I wanted to emulate them and ultimately wanted to try and take things forward again. My job is now, as I'm mid-50s, is to make sure not only do I carry on what I'm doing, but to make sure I can support the next generation that are coming through in the same way other people supported me.
That's brilliant, thank you. It's quite packed in there. So at the minute, what is your role? Because we've already talked about how you basically work everywhere, home, the university, NHS. So what is your formal role at the minute?
Okay, so my Professor of Cardiovascular Nursing at John Moores University in Liverpool. I'm also the lead for the Liverpool Centre for Cardiovascular Science in John Moores. The centre is a multi-centre, multi-stakeholder centre. So it has the University of Liverpool, ourselves, and pretty much all the NHS organisations in the city region. And my role is to coordinate and manage some of that activity in the university.
Okay, perfect, thank you. So, inquisitive, professor, teacher, work in the NHS. Tell me about the research bit.
I suppose I'm quite eclectic in the research. I don't take my own advice really. I say to people that you should really be focused on what you do, but any research that interests me, that I think can make a difference to patients or to people, then if nobody else is doing it, then I'll think, okay, well, why is nobody doing it? Let's do it. So it ranges from everything from we've put sensors into shopping trolleys and identified people in atrial fibrillation when they've pushed the trolley around the store, to looking at clinical decision making in the coronary care unit, to looking at why do certain patients not attend cardiac rehab, and if they do attend, why do they not stick to the plan, and why do they leave halfway through. So we developed, or rather we're in the process of developing a new model of cardiac rehab for different groups. We've done cardiovascular screening in the community, we've done other AF type studies. So we're doing stroke studies where we're looking at AF after a stroke to see, because we know that people who have AF after a stroke tend to, if they have a second stroke, tend to do much worse, using bands. So anything that I think that's actually got the potential to improve patient care and nobody else is doing it, then okay, let's just do it then. So it's quite eclectic. There's no plan. I think that's probably, I say to people all the time, have a plan, let's stick to the plan, but I'm probably my own worst advert for just let's just do it if it interests me.
Oh, it makes me feel so much better, because I am similarly, I'm much earlier in my journey than you are, but I very similarly tend to be slightly eclectic. But I think even in your eclecticness, as you're speaking, one of the things that I keep hearing is that you're, in a way, within your research, and correct me if I'm wrong, it sounds like what you're trying to do is, instead of get patients to mold to our existing system, you're trying to investigate and learn and research how can we get our system to go to patients. Is that correct?
Right. We often talk about hard to reach groups, and my mantra is they're not hard to reach, we're hard to access.
Oh, I love that. It's so true.
So in effect, we set up these services and then we expect people to just fit into the services. And that's very difficult. We've been joined by one or two people, I think, on the trolleys.
We'll give the trolley a minute.
It's not a shopping trolley, there's no sense in it. I think it's a tea trolley.
I didn't say it's part of the fun of doing this in the wild. Unfortunately, the lights are going to go off and on. People are going to go by.
That's part of outside broadcasting, I suppose.
It's all part of the vlog experience.
Never worked with animals, children, or
members of the public. Anyway.
But ultimately, as I say, we design these services, the professionals design services, and then we just expect people to fit within them. What we have to be better at doing is one, co-production of services, so people have much more of an input into how we deliver services. But also, we need to stop thinking of people as being this one homogenous group, that what fits for one fits for all, and we know that's not the case.
Yeah.
So some of the work that we've done by taking cardiovascular screening into the community, working with, for example, Liverpool Football Club obviously in Liverpool, where some people will not engage with authority because they don't trust us, and therefore we have to look at ways of breaking down those barriers. One of the ways that we can do that, we talk with Liverpool Football Club, we often talk about the power of the badge and how that badge can get us into places that maybe the trolley's going back where maybe we wouldn't get in on our own. So if I walk in a charge nurse uniform, for example, then there might be some mistrust there. So the power of the badge allows us to get into those areas, and then once we've developed those, and some people have then vouched for us, given as gatekeepers, allowed us to go into those areas, then we can develop those relationships, then we can start to have an impact. And we've done the same with the South Asian community, is that we need gatekeepers in those communities to help us to access. When we're in there, when people start to trust us, then we start to understand a little bit more about what their needs are. I don't necessarily know what their needs are. I'm a white, now middle-class man. I don't have that lived experience that they have. I need to go in and listen to them and try and find out what it is that they need, and then help them work in either co-production or collaboration to try and come up with something that works for them and not just for me. That's
intriguing. So it's interesting that you find that even within the nursing profession, because you read papers and you hear that, I mean, until probably recently in the UK with all the fracas around nursing, that nurses are the most trusted profession, but you found that actually you're better off to go through a gatekeeper. What do you mean by that term,
a gatekeeper? Is somebody that's going to give us access to that community. Okay. So absolutely, you're right. Year on year, nurses are the most trusted profession, and I think, and I don't want to decry from that at all, because I think we are trusted. But ultimately, as a professor of nursing, I'm not the staff nurse on the ward or the district nurse. I'm actually somebody that's coming in, and I deliberately won't wear. I've got a suit on today because we're at a conference, but I will turn up in jeans and a t-shirt. Actually, that's what I wear normally, jeans and a t-shirt. So I will turn up, but we need people in the different communities to say to them, it's okay to do that. One of the reasons for that, and I'll give you an example, perhaps just to elaborate on that, is that when we started to work in some of the communities in Liverpool, one of the things that we were accused of was, well, you'll come in, you'll take all what you need, and then you'll disappear, but nothing will change. So what we've had to do, and what we've wanted to do, is to say, no, we're coming in, but this is a long-term relationship. So we're coming in, we want to work with you, we want you to help you to improve the health of your community, but we're not going away, we're not going anywhere, and we will be bringing some student nurses with us, and they will have a better understanding of what it's like to live in this community, and so that when the patients are under our care, they have a much better understanding of the challenges that some people are facing in their lives. And that's not just Liverpool, that's all areas that I've worked in. It's ensuring that we understand the community that we serve, and we work with them. I'll just let that trolley go past again. I'm not sure if it's a train actually. It's getting louder and louder. I was going to say, every time it goes by it's a little louder. It is, yeah. They're trying to tell us something. But ultimately, when we're working within communities, it's about, I call it drive-by research, where you go in, you do the research, you disappear, you never go back until you want to do more research again. I see. And what I'm trying to do within, and it's working very well, because the people in Liverpool are amazing, absolutely amazing. But we're going in and we're saying, we want to work with you for the long term. And now those relationships built, they don't call me Professor. Some people will say Professor Ian or whatever when we're at different meetings, but it's Ian, and I know them by their first names. So when you break down those barriers and you develop those relationships, then we can achieve more together, and ultimately the community can benefit. We can then use, of course, we can use the research and the evidence from that to inform other areas of the country, and ultimately we're aiming to generalise from that. But in the short term, it's about trying to serve that community. I keep using that word, serve the community, because ultimately the community that I come from in South Wales, has got equal challenges to other parts of the country, but it's some of the inequalities and the underinvestment I've seen in those areas, certainly after, in Wales it's after the mining communities were destroyed in the 80s, but we're now dealing with some of the legacy of that, and I want to try and people like me want to try and go in and support that, but it takes time, it takes those relationships.
I find that such a fascinating model, because I think where I'm at the beginning of my career, trying to reach out and to be more inclusive, and rather than expect patients to come to us to match us, is actually what are the things that they find interesting, what are the things that they're struggling with, and how can we bring health and better health to them. And so I'd actually argue then is, despite the fact that your research on the surface of things being cardiac rehab or arrhythmia or all of the other things that you listed, I would argue that your research actually is all about the same thing.
It's about engagement in the community and supporting that community. When you look at improving the health of a community, I can't look at it purely from a cardiovascular point of view, because ultimately the risk factors are the same for cancer as they are for cardiovascular disease, as they are for diabetes. But also we need to stop thinking of it purely from a healthcare point of view. So if you live in a community where you don't have access to areas for children to play, or there's high levels of pollution, or there's Lisa Nandy, who is the local MP for Wigan, wrote a book that I read recently, and one of the things she talks about is that if you don't have appropriate transport infrastructure, it means that you can't get to the decent jobs. So what then happens is people move to the cities because they need to be there to be able to work, and you've actually taken the income out of that town. So the cities are progressing and developing, but the towns are then struggling. So what I want to look at is, can we start to think on a macro scale of what do we need to think about health? And it's the wider determinants of health that we've known for many, many years.
Yeah.
But we are still in isolation as healthcare researchers. We are still thinking about, well, I need to help somebody reduce their cardiovascular risk factors. Well, actually, some of those things are on the scale of things. They're way down here. But actually, the one thing they're worried about is their housing, or their children going to school, or the safety, and all these different things that need to be factored in. And it's only when we start to think about health of communities rather than individual disease processes, then we start to think about, well, how do we do that as a society, not individual researchers? What my job is to try and generate some of the evidence to support that potential change on a macro scale by providing local level research or national research.
So, from a research perspective, how do you do that? Because, like, when I'm writing a protocol, and even in my PhD, one of the biggest things that I battled with and struggled with was the huge level of complexity that my project just seemed to inherit for some odd reason. And it was looking at a single population, it was looking at burden of treatment, and it was looking at how patients are managing their illness. So it wasn't actually as complex as what you're proposing. So when you're thinking about developing a research study, how do you do that with that high level of complexity?
I think with any smaller research study, and I don't mean that because I've done a PhD myself, and in the grand scheme of things, it's massive at the time, but it's small in the grand scheme of how much research is going on. So you cannot do all that I'm saying as an individual. So what you're trying to do is to generate some evidence to support the next stage. So if you're able to work within a community and you're demonstrating, if you do this, you get these potential benefits to that. You can then start to chip away at some of the other things, some of the policy initiatives. For example. So you can work with local councils to say, are you aware that this is the prevalence of disease in these areas? I know that there's lots of local level data available, but very often much of the disease is undiscovered. So we know that roughly 300,000 people have AF that's undiagnosed, for example. We know that hypertension is one of the probably the biggest contributor to disease, but much of that is undiagnosed. So what we can do is to start to illuminate some of these things, and then start to work on the wider policy initiatives to start to say, well, if we know, for example, that air pollution is now becoming more and more of a factor, well, that's why obviously in London they start to look at ULEZ zones and so on. As complicated and as controversial as that is, from a public health perspective, it is something we need to consider. But you can't, as an individual researcher, you can't do that in isolation. What you can do is you build the body of knowledge, and then you are working with other people, and you are working on sometimes on a global scale, desperately trying to address some of these issues. But it is, you have to chip away at it rather than, because otherwise if you try and design a study for all these different things, it's multi-million pounds. I'd love to do the work, but it's multi-million pounds. And at the moment, I don't think there's the political will to do that. What we have to do is to generate the evidence to push that envelope and say, we need to do this because people are actually dying, and we could prevent some of these deaths. Interestingly, in Amsterdam recently, at the European Society of Cardiology, they were looking at the prevalence of cardiovascular disease, and it's actually plateauing, and it could even be going back up again, because we're now seeing that whilst smoking has reduced, obesity is increasing and diabetes is increasing. So we could actually be on the peak, or rather on the plateau and going back up again. So we still haven't cracked it, because whilst we deal with one area, there are still many of those other determinants of health that are impacting. So it's like sticking your finger in the dike. If you do it for so long, you can end up with something else going over there somewhere. So we've got to have a holistic approach to healthcare.
I really like that, because I think, you know, for people who are at an earlier stage, and I think even people at a bigger stage, it's that you're not doing it by yourself. It's that wider team, and it's about you do this little piece. But something that you said that I really liked, and I think it cycles back to what you said about you're trying to build research that's a long-term relationship within the communities, is that you then partner with policymakers, with community people, with the actual people of interest, with leadership and all of that, all of those other components. And I really like that, and that's probably, from my point of view, one of the better definitions, and again, if I've gone off track here, please correct me, of impact.
Yeah. I mean, it's interesting because what you're describing is actually public health.
Yeah.
And so in nursing, we're sitting over here with many of us coming from an acute background and seeing the end stage. And when people ask me about, well, why are you doing all this work? And I said, I've spent 30 years defibrillating people. You know, you get to a point and you think, okay, we need to do something more on this. And it's actually having that public health model that I'm not, you know, I don't come from a public health background. There may be people watching this that were saying, you know, well, you know, we've been doing this for years, and they have. But it's actually what I can do is, and as Professor of Nursing, I can actually start to put more weight behind some of those public health professionals to help them, because they have the skills already. I can actually say, well, I'll put a whole group of nurses behind you as well, and student nurses behind you, to help you to get to where you need to be, because actually you've been doing it right all along. We've been focusing on the acute management, which is important. Don't get me wrong, we need to stop people dying. But actually, if that's all we focus on and we don't invest in public health, then we end up with what we've had for the last 70 years in the NHS.
So again, it's that multifaceted, and it's very interesting, because I've started thinking the same way. Like, I fell in love with research within a more rehabilitation community setting, but then I was like, oh, no, I've got to go more acute. I've got to get where it's good and exciting. Done that, I've done research in that, and now with my PhD I'm kind of thinking similar to what you're saying. Actually, it's bigger, it's about that community engagement. Very quickly, because I'm conscious of the time, and like you said, we are at a conference and you are due to speak. For everybody who might be listening to this, what advice would you give them around why they, as nurses or physios or somebody who's in the clinical setting, why should they look at getting involved in research?
Okay. It goes back to the point of, we are delivering care on a daily basis. How much of that care are we sure actually has evidence to underpin it? So if I'm about to give a drug, I'm pretty confident that there's a number of randomized controlled trials and a meta-analysis attached to those that are telling me that this drug works. But I could be doing something for a patient that I've done for 10 years, and I'm doing it because somebody told me that's what we do. And we need to progress from that. We need to ensure that we have evidence to support our practice, whether that's physio, nursing, interdisciplinary. It's ensuring that we've got the evidence to support our practice, because we could be harming people without knowing, and ultimately that's, you know, we're better than that, and we need to be better than that for the future.
I absolutely love that, and I think it's so true. Like, so much of research is so medically driven, and it's all about the drug or it's all about the device, and medicine and health is so much bigger than that. So
even with the medicine, I presented a couple of years ago at a conference where I said that I've been working with the South Asian community and many cardiologists in the audience. I've been working with the South Asian community, and one patient said to me while I was interviewing them that I don't know which ones of my drugs are halal, so I don't take any of them. So we've got all these drugs that are evidence-based, but actually if people don't take them, if they sit in the cupboard, they have no benefit on their blood pressure or their heart failure or whatever. So it's only by working with people and understanding their needs that are we likely to see the outcomes that we see in randomized controlled trials that we're likely to see in clinical practice. So it is about that shared decision making. It is about that negotiation, whether that's at a micro level with patients or whether it's a macro level with society.
Oh, that's fascinating. Thank you for bringing that up, because I think that just ties everything together really, really well. Thank you so much for joining us today. I definitely might have to hit you up for a little bit of a longer session, because I feel like we've gone really, really quickly. But being at a conference, I wanted to just take the opportunity to do this in person instead of through a screen. So thank you very much for joining me today, and good luck at your presentation later. All right, thank you.
Thank you.
Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. Wow, that was exciting. Lots of trolleys going by, lights going on and off. The video didn't come out, but hopefully the audio will be okay, because it was a really interesting conversation with Professor Ian Jones as I squeezed between one meeting and his presentation that he has later today. My top 3 takeaways from that conversation with him. I loved his revolutionary idea around taking health and research to the people. You know, as clinicians, we are always having patients come to us, and yes, that's more convenient, but I think some of his ideas and some of his work that you can find out and read about in the description below, he's really strong advocate about doing research with the community and in the community as part of an ongoing long-term relationship aimed at improving health overall. And I really liked that idea. My second takeaway leads on from that is his passion about building and embedding research within the community, so that research becomes just as much a part of a community as a GP surgery, a football pitch, or whatever, and that he's recognized as a leader in that community, as somebody who, you know, might be interested in a problem that you have and could come up with a research study to try and better answer or solve a problem. And I think that's a really unique model, and I'm very grateful to hear more about it from him. My final takeaway is something that is near and dear to my heart, because I seem to get into a lot of complexity in my own research, is his reminder to us that we don't have to build in all the complexities and all the nuances that health has in a single research project. That actually it's about chipping away at a bigger problem and slowly building the evidence around that problem, so that when we can put all of those different puzzle pieces together and we can work with our community, we can work with policymakers, we can work with charity groups, and we bring their evidence together too, so that we can then change health within our communities. And I loved that idea and the freedom that comes from that idea, that you don't have to put it all into a single research project. That's definitely something I'm going to take away and put into play in my own research proposals. So that was it for this very first Researcher Revealed in the Wild. Let me know in the comments if you liked it, if you want to see more of it, because I do go to quite a lot of conferences and they tend to be quite busy, so I can see who I can manage to corner and get a little bit of their time. Don't also forget to like and subscribe to this, because that really helps me grow this channel, which will hopefully eventually make it so that I reach 1,000 subscribers, and yeah, I'm able to do this more and share more research stories with you. Thank you so much, and I will see you again soon.